this is a demonstration combining the Nova iTrack catheter and Glaukos' new iDose. And so what you're going to see here, this is the new iTrack Advanced. And so I'm creating a small goniotomy here in the trabecular meshwork. This is going to allow for unobstructed movement of that catheter right into the canal, which you can see here. That illuminated tip is always showing us where we're going. I'm encountering a restriction right there, so I can't get this thing to advance any further. I'm doing a couple of clicks of viscoelastic and then trying to push it back forward again, and again I can't get through. And so in situations like this, my preference is to come back out and try to go the other direction. The majority of the time when you go the other direction, you don't really have any difficulty passing this through the obstruction you encountered the first time. And so now you can see I'm going in through my parawound here, right into that same otomy location. I'm going to advance that illuminated catheter around and try to get to the first obstruction we had. And so here you can see the advancement of that catheter, that blinking light indicating exactly where we are and making it very easy to know your location inside of the eye. And so here we're approaching the 180-degree mark. As I'm coming around, I'm noticing I'm hitting another restriction right there. So I can't get that catheter to advance any further. I'm going to retract like you just saw, inject some viscoelastic and then push forward again, but I can't get past it. So this is one of the few scenarios where there are a number of restrictions within the canal and I can't get a full 360 degrees. So we're going to treat what we can get to. Once that's out, the majority of the time, what I would have done in 2024 is then insert something like a hydra stent to try to hold all that work open and keep that canal flowing freely. We're unable to do that anymore, and so my new go-to is introducing an iDose when I can. And so for this scenario, we're going to put the iDose in. You're going to see it coming here on the side. The iDose is very much like a pellet, like a dart, I mean. So it's got a sharper tip and a kind of a longer insertion device, and the goal isn't necessarily getting it into the TM, it's getting into the actual sclera itself. So you have to use a little bit more force when you're pushing the injector or the iDose instrument into the scleral wall. And so here we're going to advance it, and you're going to see it coming in just like that. I'm slightly off kilter because I make my primary incisions for cataract surgery at about 220 degrees. And so now you can see me indenting against the scleral wall there. Then I'm going to release, so I'm going to let that come back into position. I know it's securely anchored. I then open the inserters and slide them backwards. The goal is to not grab the tip of that by accident. They don't open super wide, so it's very easy to capture an edge of that injector. And so this is a different patient having pretty much exactly the same procedure, so a secondary demonstration. Again, the iTrack Advanced, I'm creating a small goniotomy, a little bit of heme, so I know I've opened up my area. I'm then going to advance my illuminated catheter. You can see it going around right there. So now we are in the canal. We're going to shoot to go for 360 degrees. I apologize, this one's a little off center, but here you can see that blinking catheter tip going along around the 180 degree mark there. And here it's going around to 270, and then I think this one's going to make it the full 360. And so we see that illuminated catheter tip come all the way around for 360 degrees. I'm then going to retract it. Once I get that retracted, if I do think there's enough heme here to obstruct my view, we are going to use a little bit of viscoelastic to kind of push that heme out of the way so we get a nice view. While this gets set up, there's the viscoelastic. So now we've opened up the angle a little bit. We've cleared up our view. You're going to see a little pop there for me editing the video to make it easier and more concise. So here, again, the dart of the iDose injector, we're going to indent it into the trabecular meshwork. We're going to set that thing right into the sclera. So you have to give it a little bit of a firm push that you see there. The second you feel like it's firm and in place, I'm going to back out slightly or just release that pressure and then open the injector forceps right there and pull straight back, trying not to grab the edges of the iDose. You want to tap it a little bit, make sure it's firmly in location. Once it is in, you're going to come off the eye, you're going to straighten the eye and the face, and then when we are doing our viscoelastic removal, just keep watching your iDose. So this is a beautiful example of being able to see the iDose in location. We're going to take out all the viscoelastic. We're going to watch for that iDose to stay stable. I don't want to see it jiggling around in here. And then at the very end, we're going to actually while we're hydrating our wound, shoot a little BSS right at the iDose to see if we can make it flick around at all. If it stays nice and stable, we know it's got a firm anchoring location and it's not going to dislodge from the sclera. And so this is a nice nice view of that right here, and it's a really great example of seeing the iDose after it's been implanted. And right here we're going to bring in our BSS and we're going to hydrate the main wound, and then when I get to my pair, I'm going to shoot it right at that iDose and try to see if I can get it to wiggle around a little bit. And you can see here it's firm and anchored in location. Don't have to worry about that thing slipping out of the eye. Thanks for taking the time to watch this video.